If you notice this warning sign while taking amlodipine, stop the drug right away and contact your doctor. Doing so could be life-saving. What follows may upend what you thought you knew about one of the most common blood pressure medicines. There are a dozen adverse effects that manufacturers must disclose, yet many patients never link their symptoms back to the pill they're taking. Number 8 on that list is overlooked so often that it accounts for emergency department visits in 15% of long-term users. And it could be happening to you without you realizing it. Amlodipine ranks as the 6th most frequently prescribed medication in the United States, with more than 70 million prescriptions filled each year. That's roughly 1 in 3 adults over 40 currently using it. Yes, it's highly effective at lowering blood pressure, with major trials showing up to a 64% reduction in heart attack risk. But the newest post-marketing safety data also indicate that 1 in 8 users reports an adverse reaction. And here's the troubling part. For every report that gets filed, researchers estimate about 10 more go unreported because people don't suspect their medication is the culprit. Let's be absolutely clear before we go any further. This program is not advising you to abandon your prescription. Doing that on your own would be risky and irresponsible. Some will say all drugs are harmful and should be avoided. Others assume that anything widely prescribed is automatically safe. Both viewpoints miss the mark. Our aim is to inform, not alarm. When you know the signs, you and your healthcare professional can navigate treatment more safely and effectively. Over the next 10 minutes, we'll break down the 12 most serious side effects of amlodipine that every user should recognize, including the one that impacts roughly a third of users, yet is rarely discussed when the prescription is first written. This content is for education and general information only. It is not medical advice. If you have questions about your health or symptoms, speak with a qualified clinician or, in an emergency, contact local emergency services. All material has been carefully researched and vetted, and the source references are available in the video description. 1. Skin rash. Skin rash covers a wide range of dermatologic reactions linked to amlodipine, from minor localized changes to rare but life-threatening conditions. The most frequent presentation is a maculopapular eruption, responsible for roughly 41.7% of reported skin events, featuring flat red spots, macules mixed with raised bumps, papules that may itch or feel tender. In uncommon instances, amlodipine can also precipitate severe dermatologic emergencies such as Stevens-Johnson syndrome and toxic epidermal necrolysis. The underlying biology involves complex immune pathways that include both immediate and delayed hypersensitivity reactions. Type 1 responses typically appear within minutes to hours and are mediated by IgE antibodies, whereas type IV reactions evolve over days to weeks, driven by T-cell mediated mechanisms. Which pathway predominates varies by individual immune profile and by the specific rash that develops. Clinically, a maculopapular rash is a widespread symmetric eruption that usually involves the trunk, arms, and legs. It begins as flat, erythematous spots that can progress to raised lesions, frequently accompanied by pruritus or a burning sensation. Some patients may also develop a petechial pattern, tiny red or purple dots caused by superficial bleeding under the skin. Severe reactions like Stevens-Johnson syndrome require urgent medical attention. Amlodipine should be discontinued immediately, and specialized care is essential to prevent complications such as infection, fluid and electrolyte imbalance, and multi-organ failure. Early recognition and prompt intervention are critical. 2. Severe psychological effects. A subset of patients on amlodipine experience profound anxiety, depressive symptoms, and marked mood changes that can be disabling and disrupt daily life. Panic attacks may occur, arriving suddenly with intense fear, racing heartbeat, sweating, and a sense of impending catastrophe. Some people describe feeling as if they are dying or overwhelmed by anxiety that seems to appear without warning. The severity can interfere with work relationships and routine tasks, and in some cases leads to agoraphobia, a fear of leaving home or entering situations where escape might feel difficult. Sleep problems are common, including insomnia, nightmares, and frequent awakenings. Poor sleep then intensifies both anxiety and depression, creating a self-perpetuating cycle. Depression during amlodipine therapy can present as persistent low mood, loss of interest or pleasure, feelings of worthlessness, and thoughts of self-harm. Appetite may swing in either direction, concentration and decision-making can suffer, and the depressive state may respond poorly to standard antidepressant treatments as long as the medication is continued. Mood lability and irritability are also frequently described with rapid shifts between emotional states. Family and friends may notice personality changes or heightened aggression. The psychological burden can be so significant that it undermines relationships and social functioning. Early recognition is essential because these manifestations can be misidentified as primary psychiatric disorders rather than adverse effects of the medication. 3. Gingival hyperplasia. Gingival hyperplasia is a distinctive oral complication of amlodipine marked by an abnormal enlargement of the gums that can create both functional and cosmetic challenges. It affects an estimated 1.7% to 3.3% of users, with men showing a notably higher risk. Enlargement often begins within the first 3 months of therapy and may advance considerably if not addressed, sometimes partially covering teeth and disrupting normal oral function. The proposed mechanism centers on the drug's effects in gingival tissues. Calcium channel blockade can disturb calcium handling and skew the balance between collagen synthesis and degradation, leading to excessive buildup of fibrous connective tissue. Dental plaque and local irritation amplify this process by provoking inflammatory responses that further drive tissue overgrowth. Clinically, the earliest sign is a subtle thickening of gum tissue, especially in the interdental areas where plaque commonly accumulates. As it progresses, the gingiva becomes more prominent and firm, with a fibrous feel, differing from healthy gum texture. Depending on the degree of inflammation, the tissue may appear pale pink or reddish. Functionally, overgrowth can make routine hygiene difficult. Effective brushing and flossing become harder, while also interfering with chewing speech and even proper dental alignment. The cosmetic consequences can be substantial, particularly when anterior teeth are involved, leading to social embarrassment and a meaningful decline in quality of life. 4. Taste disturbances, dysgeusia. Amlodipine can trigger profound alterations in taste perception, including a complete loss of taste, a condition referred to as dysgeusia. Though uncommon, this effect can appear abruptly and often involves the anterior 2/3 of the tongue, where taste receptors for sweet, salty, and umami are concentrated. Presentations range from partial reduction in taste to complete ageusia, in which no flavors are perceived at all. People may notice a persistent metallic or bitter quality, or find that everything tastes the same and unpleasant, turning eating into a discouraging experience. This disturbance can also blunt the ability to recognize spoiled foods, introducing risks such as foodborne illness. The consequences for nutrition and daily life can be considerable. Without the normal pleasure of flavor, many individuals lose interest in meals, which can lead to weight loss, micronutrient deficiencies, and withdrawal from social settings that involve food. The psychological toll can be significant as well, because taste is closely intertwined with memory and emotional well-being. While the precise mechanism is not fully defined, interference with calcium channels in taste receptor cells is suspected to disrupt normal signaling and produce these sensory changes. 5. Severe cardiovascular effects. Paradoxically, amlodipine can aggravate chest pain, or even trigger heart attacks in certain individuals, especially when therapy is started or the dose is increased. This is attributed to coronary steal syndrome, in which the drug preferentially dilates healthier coronary vessels more than diseased ones, potentially diverting blood away from myocardial regions already threatened by arterial narrowing. In vulnerable patients, the consequence can be intensified angina or even myocardial infarction. The medication may also provoke marked hypotension, producing dangerous drops in blood pressure that lead to fainting, falls, and injury. When pressure falls too quickly or too far, vital organs may receive insufficient perfusions, risking organ dysfunction. People can experience dizziness, lightheadedness, generalized weakness, and in severe episodes, loss of consciousness. Arrhythmias are another serious concern, including bradycardia, where the heart rate slows to unsafe levels, and tachycardia, where it becomes excessively rapid. Such rhythm disturbances impair cardiac output and may necessitate urgent treatment. Patients might report palpitations, chest discomfort, or shortness of breath accompanying these irregular rhythms. These cardiovascular reactions are particularly hazardous for older adults and for those with pre-existing cardiac disease. Reflex tachycardia can develop as the body tries to compensate for lowered blood pressure, increasing myocardial workload and oxygen demand. Close observation is critical with special attention during the first weeks of therapy when these events are most likely to occur. 6. Extrapyramidal symptoms. Extrapyramidal symptoms are rare but serious neurological complications linked to amlodipine that resemble the movement disorders more commonly associated with antipsychotic drugs. They reflect dysfunction within the extrapyramidal system, which governs involuntary motor control and coordination. Clinical features can include muscle rigidity, tremors, involuntary movements, and dystonia, any of which can meaningfully limit mobility and diminish quality of life. Dystonia. A hallmark of these reactions consists of sustained muscle contractions that provoke twisting repetitive motions or abnormal postures. People may develop cervical dystonia with the neck turning involuntarily, or limb dystonia that alters the resting position of an arm or leg. These episodes are often painful and socially distressing, sometimes leading to withdrawal and a further decline in overall well-being. Additional manifestations may involve generalized spasms, inner restlessness known as akathisia, and oculogeric crises in which the eyes deviate upward without control. Difficulties with voluntary actions can also arise, including problems with speech, swallowing, or walking. The tremor pattern is typically a resting tremor that is shaking that appears when the affected body part is at rest. Although the precise mechanism remains uncertain, interference with dopaminergic pathways in the brain is suspected. Because these symptoms strike at fundamental motor functions, they can be profoundly disruptive to daily activities. Prompt recognition is essential, as extrapyramidal reactions may be mistaken for other neurologic conditions, potentially resulting in inappropriate management. 7. Peripheral neuropathy. Amlodipine. Associated peripheral neuropathy involves injury to the peripheral nervous system and leads to disabling sensory and motor symptoms. The nerves outside the brain and spinal cord are affected, with the hands, feet, and legs most commonly involved. People frequently report numbness, tingling, and a burning quality of pain that can interfere with daily function and overall quality of life. Early signs are often subtle, such as pins and needles in the fingertips or toes. As the disorder advances, touch perception may decline, making fine tasks like buttoning clothing or manipulating small objects difficult. The burning pain is particularly distressing, often likened to fire or stabbing sensations in the affected areas. In more severe cases, weakness and balance impairment can occur, increasing the likelihood of falls and related injuries. Walking becomes challenging, especially in low light or on uneven ground, due to reduced proprioception, the body's sense of position in space. Temperature discrimination may also be impaired, creating risks when handling hot or cold items. The neuropathy can be related to dose and may arise gradually over months or years of therapy. Some individuals notice improvement after stopping amlodipine, though recovery is often slow and may be incomplete. The precise mechanism is not fully defined, but interference with calcium channels in nerve cells is suspected to disrupt normal signaling and contribute to progressive nerve degeneration. 8. Hepatotoxicity, liver damage. Though uncommon amlodipine-associated hepatotoxicity is a potentially life-threatening complication that can emerge quickly after therapy begins. Reports describe marked rises in liver enzymes, alanine aminotransferase, ALT, and aspartate aminotransferase, AST, within days to a few weeks of initiation, signaling hepatocellular injury. In one documented instance, a patient developed severe hepatic toxicity after only 1 week of amlodipine presenting, with fatigue, nausea, abdominal discomfort, and jaundice, the yellowing of skin and eyes driven by elevated bilirubin. Laboratory evaluation showed enzyme levels exceeding 10 times the upper limit of normal, indicating significant hepatic damage. The proposed mechanism involves drug biotransformation, with formation of reactive metabolites that injure hepatocytes. Injury can advance rapidly and, in some cases, evolve into acute liver failure, requiring urgent medical care. Hospitalization may be necessary for close monitoring and supportive management. Most cases improve after prompt discontinuation of amlodipine, though convalescence may take weeks to months. In severe presentations, lasting impairment is possible. Patients should be observed for features of liver dysfunction, fatigue, nausea, abdominal pain, dark urine, and yellowing of the skin or eyes, and evaluated without delay if these symptoms appear. 9. Angioedema. Angioedema is a potentially life-threatening hypersensitivity reaction marked by sudden deep swelling of the skin and mucous membranes, most often involving the face, lips, tongue, throat, and upper airways. Unlike surface-level rashes such as hives, angioedema affects the deeper dermis and subcutaneous layers, producing uneven asymmetric swelling that can arise within minutes to hours after exposure to amlodipine. Because airway narrowing and respiratory compromise can develop quickly, this condition requires urgent medical evaluation. The underlying process in amylopoietin-associated angioedema involves the release of inflammatory mediators, particularly histamine and leukotrienes, that increase vascular permeability, allowing fluid to accumulate in local tissues. Both allergic and non-allergic pathways may be involved. In some individuals, complement activation or bradykinin-mediated mechanisms contribute to the reaction. Clinically, the swelling often feels firm or woody, helping distinguish it from other causes of facial puffiness. Symptoms commonly begin with tingling or a burning sensation, followed by rapid enlargement of the lips, eyelids, or tongue. If the swelling extends to the throat and airway, people can experience hoarseness, difficulty speaking, trouble swallowing, or shortness of breath, signs of a potential medical emergency. A key danger is unpredictability. Angioedema can occur even after long-term previously tolerated use of amlodipine. Mild episodes may subside within 24 to 72 hours, but involvement of the airway demands immediate treatment, with antihistamines and corticosteroids and epinephrine may be necessary. In severe cases, intubation to secure the airway can be required, making early recognition and rapid response essential. 10. Peripheral edema swelling. Peripheral edema is the most troublesome adverse effect reported by amlodipine users, affecting roughly 10 to 15% of people taking this calcium channel blocker. It appears as visible swelling of the ankles, feet, and lower legs, creating a puffy look that often worsens as the day goes on. The reason is tied to how amlodipine lowers blood pressure. The drug relaxes and widens arteries, which reduces pressure, but also makes it easier for fluid to move out of the bloodstream and into nearby tissues. In the lower limbs, where gravity naturally draws fluids downward, the relaxation of smooth muscle and arterial walls increases vascular permeability, allowing plasma proteins and fluid to seep into the interstitial spaces between cells. This disrupts the usual balance of fluid exchange that keeps tissue hydration in check. Women tend to experience this swelling more often than men, and the effect is clearly dose-dependent. At the lowest therapeutic dose of 2.5 milligrams per day, reports suggest about 1.8% of patients develop edema, When the daily dose reaches 10 milligrams, that figure rises to approximately 10.8%, illustrating how higher exposure amplifies the problem. The onset is typically gradual over several days to weeks after starting therapy. People often notice shoes feeling tighter or sock marks that linger after removal. Although usually painless, the edema can create a sense of heaviness, discomfort, and difficulty with everyday activities, such as walking or wearing regular footwear. 11. Flushing. Flushing is a vasomotor reaction marked by sudden warmth, facial redness, and visible color changes over the face, neck, and upper chest. It arises directly from amlodipine as pharmacologic action. The drug relaxes vascular, smooth, muscle-widening peripheral blood vessels and shunting more blood to superficial skin layers. This peripheral vasodilation, especially pronounced in the head and neck, raises skin temperature and produces the characteristic reddened appearance many patients describe as a hot flush. Episodes can be erratic, lasting from a few minutes to well over an hour, and may range from mild warmth with slight discoloration to intense heat and pronounced redness, sometimes accompanied by sweating or feeling overheated even in cool environments. For most people, the frequency and intensity tend to diminish over several weeks as the body adapts to the medication, though occasional recurrences can persist. While medically benign, these flares can be awkward or embarrassing in social and workplace settings. 12. Constipation. Constipation is a notable gastrointestinal adverse effect of amlodipine, presenting as infrequent, difficult, or incomplete bowel movements that can cause substantial discomfort and downstream health issues. By blocking calcium channels in intestinal smooth muscle, the drug reduces motility, slows transit, and allows greater water reabsorption from stool-yielding, harder, drier feces that are more difficult to pass. Compared with combination regimens, amlodipine used alone has been associated with a roughly four-fold higher risk of constipation. Patients often report bloating, cramping, a persistent sense of incomplete evacuation, and decreased stool frequency, frequently accompanied by excessive straining. Severity spans mild to debilitating, and some cases require clinical management. Left unaddressed, chronic constipation can lead to hemorrhoids, anal fissures, fecal impaction, and an elevated risk of urinary tract infections, particularly among older adults. If this helped you spot what others miss, don't let it end here. Hit subscribe and tap the bell so you never miss the next deep dive into safe, smart health decisions. Share this video with someone who needs it today, and drop a comment with your questions or experiences. We read every single one. Your story could be the spark that protects another life. Stay informed, stay proactive, and I'll see you in the next episode.